Let me introduce speakers for Session 2. Session 2 for current status of the model integrated bioequivalence for long-acting injectable and implantable drug products has two speakers. In order of presentation, Andrew Hooker, PhD, is a professor of pharmacometrics at Uppsala University in Sweden. Dr. Hooker's research includes both methodological and applied pharmacometrics. Dr. Hooker is also a co-developer of a number of software programs that are freely available for building and using population pharmacometrics models. Maurice Ducharme from the FCP is the president and CEO at Learn and Confirm Inc. Canada. Dr. Ducharme has 30 years of academic, clinical, and industrial experience in pharmacometrics, infectious diseases, drug metabolism, and clinical drug and biological development.
Hello, my name is Andrew Hooker, and I'll be talking about model-integrated methods and innovative study designs for generic long-acting injectable product development and regulatory assessment. You can see my collaborator names on the side of the slide here. So just so that we're on the same page, let's think about standard bioequivalence studies. And in standard bioequivalence studies, we have 2x2 crossover designs, which are then analyzed based on some non-compartmental analysis. And those NCA-based calculations typically take summary PK metrics like areas under the curve. You'll get 2 of those per individual, depending on the reference or test product, as well as other things like Cmax, in order to understand that curve and whether they're equivalent. And then bioequivalence is determined by comparing the 90% confidence interval of the geometric mean ratio of these NCA metrics. For each individual, you take the ratio and then you compute a geometric mean, and then you can compare to some predefined limit. Now, there can be a number of problems with these NCA-based bioequivalence procedures. One problem is with the NCA calculations themselves. These NCA-based methods are oftentimes very dependent on the data that you have available. If you have sparse data and you don't get samples in this region, then you miss a lot of the area under the curve and the Cmax. If you have trouble making measurements in this region, then you may have trouble extrapolating with the right extrapolation method in order to get AUC out to infinity. And furthermore, when you summarize this type of information, then it's hard to separate the variability sources that often this data is derived from, which may have between subject, occasion, as well as between observation variability. So let's think a little bit more about this problem of interpolating from the last observation to infinity, which may be especially important with long-acting injectable products where it may not be possible to make measurements out until the end of the last phase of elimination. So if we think a little bit in more detail about this idea of extrapolating to infinity for computing areas under the curve, we know that process can give biased estimates. Here is an example from drug-drug interaction studies where long half-life drugs were used, bedaquiline used for anti-tuberculosis treatment. And the problem with the study was that you couldn't run the study to investigate the full clearance profile. So you had a hard time extrapolating from the end of the study. And what they could see here was that with the NCA-based analysis, when they were looking at the interaction between bedaquiline and this other drug, that they could see that they expected a geometric mean ratio of AUCs between with and without that second interaction drug, a geometric mean ratio of 5, and they estimated something around 2 for all types of different designs. Whereas a model-based approach, using a model to estimate the factor change in clearance, which should be equivalent here, they could estimate quite well the true factor change in clearance, which was a reduction of the factor change was 0.2. So NCA-based methods can give problems, they can give biased estimates, but we also have other problems with BE studies, and especially for long-acting injectables where we have often very long half-lives. That means we have a long-term bioequivalence trial. We may be needing to run crossover steady-state studies in patients, which can cause problems. Of course, there's other issues with bioequivalence studies, standard bioequivalence studies that are related to NCA and related to the study themselves. If we have sparse data, then using NCA-based methods can be problematic. Highly variable drugs, lots of variability can cause problems. There's other problems as well, but I want to focus on this long-acting injectable problem. So the challenge of performing bioequivalent studies for long-acting injectables is this long half-life. If we just think of a standard single-dose crossover bioequivalence study, then with a common oral product, if you have like a half-life of about 8 hours, then you might run a study that could last a couple of days, including washout. Whereas if you have a half-life that's 40 days, then you're going to have to wait a much longer time for washout. So the study might last months, 16 months instead of 4 days in this simple example. So it's oftentimes not practical to perform a single-dose crossover bioequivalence study for long-acting injectables. So because of that, if you have the possibility of running a single-dose study, then you'll typically run a single-dose parallel study. Here's some examples where that might be the case. But there are situations with long-acting injectables where there may be a long-term side effect for healthy volunteers that take the drug. And so then you want to use the drug only on patients. And of course, if patients are taking a drug, then you want them to have some effect of the drug, so they don't have problems. And that means that you have to keep them at some steady-state concentration, which means then that we would need a multiple dose crossover steady-state study in these situations. So here's some examples of a number of drugs where that might be the case. Other problems, of course, here are if we're running a very long multiple dose crossover steady state study, there's problems with dropout. There's going to be increased variation as you go across different occasions in the study. Modeling, I believe, can help with a number of these bioequivalence problems, and they can improve the methods that we use to evaluate bioequivalence. And I think there's two basic ways we can do models. We can use models to improve bioequivalence. We can use a model-informed approach, and that's where we might use a pharmacometric model or some population model to simulate data to then understand the operating characteristics of a standard study design or some new study design and change those operating characteristics. So when you analyze it using a standard NCA-based analysis, you maybe have different bioequivalence limits. The second approach where a model can be useful is actually using your model to fit the data and using your model then to tell you whether there seems to be a difference between a reference and a test product. So integrating your model into the bioequivalence analysis. And I'm going to talk about more about this model integrated approach, but I'll talk a little bit about the model informed approach. Of course, if you have models, you can also then use those models to make simulations of what you expect to happen. So then you can design better studies as well. So you can get studies that are more efficient. So let's think about these long-acting injectable products. If we have a crossover steady state study, then typically you'll have some individual on a reference product, and you'll want to make sure that they're on that reference product. You maybe wait a couple months and measure and make sure that they're at steady state, the same C trough values, and then you would make some measurements of the concentration time profile in this steady state occasion. Then you would switch to some test product, and you'd have to wait for that individual to come up to steady state again, and then make a measurement in this steady state region. And then you would compare those two profiles. Now, one idea that you could use where we might be able to use models in order to reduce these study durations is to use something called a switch study. And in the switch study, then we would have the same start of the study where you'd end up studying the steady state profile of a reference drug. But then you would immediately after switching to a test drug, then you would measure the profile of that first iteration, the first occasion after the switch. Of course, you still may have a reference drug in the system there, and you can then use your model to either change what the bioequivalence limits should be, or use your model to separate the superposition of the test and reference products that are in this second occasion that you're measuring. So we would have a model-assisted approach, change the BE limits, model-integrated approach, derive from our model how much of what this profile would look like if we didn't have the additional drug that was from the reference product. So let's see if we can think about how this might be done. One thing I want to point out is the reason that I want to be looking at model-based approaches, so model-integrated approaches as opposed to model-assisted approaches, is that in general, you think that model-based approaches, especially population model-based approaches or pharmacometric approaches, they will typically have a higher power than standard statistical methods. This is just an example, not from the bioequivalence space. This is from an example Alzheimer's study where we demonstrated that if you ran this study in a specific situation with a standard analysis method, in this case it was an unstructured MMRM model, you would need 2,500 individuals. If you use a pharmacometrics model and then optimize also the study for that pharmacometrics model, you could reduce the number of individuals down to about 500. So you could get a massive increase in the number of power increase, so decrease the number of individuals by using a pharmacometrics approach. And this is something that you can see in a number of different publications and a number of different systems. And there's been a number of different groups that have investigated how you can use these pharmacometrics approaches, these model-based approaches in bioequivalence. So Shampoo Hu and Mark Sale in 2004 published on looking at sparsely sampled systems and identifying bioequivalence or biosimilarity. And France Montré has been working since 2010. She published one of her first papers on the topic and has been working ever since on trying to improve the methods. These methods, I'm just going to first sort of talk about the standard statistical analysis and then how that relates to a model-based analysis. And actually, the standard statistical analysis, of course, is a model-based analysis. It's just a simpler model. So the standard analysis will look at your summary statistics for each individual, and each occasion. So you'll be looking at Cmax and various different AUC calculations. And you'll use then a linear regression to compute the linear mixed effects models. You'll compute a mean value. You'll compute a treatment effect, so the difference between test and reference product. You'll compute sequence effects and period effects if you're doing crossover studies. You'll have a between subject variability term, and then you'll have a between occasion variability term, which is the same as residual variability when you only have 2 observations per individual. And then you can identify these parameters as the treatment parameters, the difference between test and reference. And you can then use uncertainty calculations to compute a 90% confidence interval of this parameter. And that confidence interval should then be within 0.8 and 1.25. And since we're in the log space, we take the log of those values. This linear regression is equivalent to testing the geometric mean ratios of Cmax, AUC, AUC last, and making sure that they fall within 80% to 125%. So in a model-based approach, instead of looking at the summary statistics, we actually look at the observations that are taken per individual. So it's the concentrations over time for PK. And then we try and fit a model to that data. And the model generally, you would expect a PK model to already be there for a reference product. It's required now when you submit a new product to FDA. So this is just an example model that one might have from a reference product. And that model would then describe the oral dosing of the drug, the absorption into the central compartment, and in this case, it's a one compartment model. So then there's just some elimination out of that central compartment. Now and this V should be divided by clearance divided by V. These parameters then will have typical values, sort of like what we saw in the previous slide with the standard statistical analysis. We'll also have between subject variability and potentially inter-occasion variability on any of these parameters. And then we will use the model to describe the data. So the data is for every individual, all the data points for that individual, and you can also specify them per occasion. So you have a model that combines all of these parameter values as well as a model for the deviation of the model to the observation, so the residual variability model. Now, the problem with this type of model in general is that we typically don't even talk about bioavailability when we only have models for oral dosing of a drug, because we can't identify the bioavailability with only oral dosing. So these models will typically not have a bioavailability term in the equations. For bioequivalence analysis, though, we think that you should definitely have a bioavailability term. And since you can't estimate it, you can set it to 1. So we're not talking about true bioavailability. What we want to make clear, though, is that what we want to estimate is deviations of the bioavailability. So the relative bioavailability between treatment, so test versus reference, between sequences or periods in a crossover study. Furthermore, we also know that if we're giving a test and reference drug in a bioequivalence study, then we know the chemical compounds are the same from other types of studies that we've done. So all we're really trying to understand is whether the absorption characteristics are the same. So we know that as long as we've taken into account the bioavailability, then all we need to test are differences in absorption parameters. So we also add differences in treatment sequence and period on the absorption parameters in the model. So we have to add extra terms into these models in order to be able to identify differences in treatment sequence and period. Note that just as we had in the standard statistical analysis, there was a between occasion variability that was measured, which is the same as residual variability for standard statistical analyses. So if a model does not have inter-occasion variability, then it should be added or investigated if you have a crossover design that you're actually running for your bioequivalence studies. So our developed model integrated approach uses that model fitting procedure, which includes extra components in any model that you may use. You may use one model, or there could be a set of models that you're using in a model averaging procedure to fit that data. And once you've then identified these treatment effects, which you now have on each parameter, you need to then transfer that information into what that means to the summary statistics, the AUCs and Cmaxes. And our modeling approach, then we estimate the uncertainty of all of these parameters that we've estimated. We use that uncertainty to simulate out populations of individuals, which we can then compute the geometric mean ratio of Cmaxes, AUCs, and so on. And you can simulate out populations of individuals 10,000, 100,000 individuals to compute these mean ratios across different parameter values that are in the uncertainty distribution that's been computed from this model fit, as well as across different models if you're using multiple models. So you can then have a weighted model averaging across these simulations. That allows you to get a distribution of the mean ratios of AUC and Cmax, taking into account treatment effects as well as the uncertainty of those calculations, which allows you to then get a confidence interval, which you can then make a bioequivalence conclusion on. We've presented this in a number of different places. And this method tends to work. Here's just one example where we were looking at a number of a situation where we had both low and high variable data. We had lots of individuals and lots of measurements, and then we had low individuals and low numbers of individuals and measurements per individual. And what you can see that in general, or always in these situations, the model-based method in red maintain type 1 error for both low and high variation in all these different situations. The standard NCA-based method actually had lower type 1 error than one expected in these situations. We can also see that the overall power, especially when there was high variation in the data, was much better for the model-based in red situations. So you can see here with few individuals and few samples per individual, then there was a large difference between the standard analysis and the model-based analysis. And that even if you doubled the number of observations per individual, you still saw that large difference. Now, I mentioned that you may want to use models or a number of different models, an ensemble of models to describe your PK data. And this could happen in a number of situations. You may not have a prior model from your reference data, so you might have a number of different potential models that could describe your data. That's maybe the less common situation. More common, you might have a model that was built on lots of different data sets that has many parameters, and maybe all of those parameters aren't identifiable in a crossover study for bioequivalence. So you'll have to reduce your model in some way, and that reduction can be done in different ways. Or maybe your model doesn't have between subject variability, inter-occasion variability, and it needs to be added and you're not sure where it should be added in the model. So you have a number of different potential situations. Furthermore, all these extra terms that you have to add into your absorption parameters, treatment, sequence, and period effects may not be identifiable for all absorption parameters in a nonlinear model. So you may have to have a reduction in that amount of parameters. So if you then have a range of models, those models are then fit to data, and then you can use those models to predict, weighting those predictions based on which models best fit the data. This allows you to avoid estimation or selection bias, and it allows you to also avoid overestimation of precision in your model-based simulations. So if you have a model or a number of models and you're trying to figure out which models you should include in a model-based approach, then of course one big problem is model qualification. Which models should you be using? Here's just at least 2 points that I think we can discuss. One is that models should be identifiable. All the parameters should be identifiable in the bioequivalence study. So you should have a model where every parameter has enough certainty that you can identify it. This could be tested, for example, using an optimal design software like PopEd, where you compute the expected uncertainty of parameters given study designs. The second qualification procedure that we use in our model-based approach is that we do posterior predictive checks of any model that's fit to the study data to make sure that that model, when simulating that same study data, can reproduce the Cmax, AUCs, the summary PK metrics to some precision. And I'll just show you an example. What we're doing here is something called the NCAPPC, Non-compartmental Analysis Posterior Predictive Check, which is a package that's available on CRAN. And we use any model that we want to include in our bioequivalence tests, simulate out the mean AUC, mean variance, the variance of the Cmaxes and the variance of the AUCs. Here's a posterior distribution from our model, as well as in red, the observed values in a data set. So you can see that our model is able to describe the data. So it seems to that extent, be descriptive enough to be used in bioequivalence. So does this actually work? Well, if we look at the long-acting injectable situation where we might want to use a switch study instead of a crossover steady state study. And remember, the switch study would be much shorter, but when you switch, then you would still have reference product in the system, so the observations are sort of contaminated. Research shows that both the model-assisted and model-integrated approaches can help you can control type 1 error, but it will require more individuals than the crossover steady state study. And how many more individuals will depend on the situation that you're looking at. We find also that the model integrated approach is always more powerful than model assisted approaches, and in some cases, many times more powerful. One last thing I would like to point out is that it's not only that we can look at this one innovative study design, but when you're not restricted by having to do a non-compartmental analysis, then you could use any number of innovative study designs. This is just an example where, for an example with paliperidone, looking at schizophrenia, where the model-based approach, one of the important parameters in estimating bioequivalence was actually the inter-occasion variability between occasions. And so in order to improve that estimation, we added observations in the second period before switch and the first period before switching to the test product, and then the test product. So we had one extra period that was measured. And what you could see is if you did a study that looked something like this, that you could reduce the study size by 10% with a relatively minor change in the study. It wouldn't change the study duration, but it would change how many observations you needed in the study. There's other groups like Franz Montre's group who have published new ways of actually testing bioequivalence. So once you've got your confidence intervals around your ratios, that you use different tests to see whether you have bioequivalence or not. So these are other methods that can improve even more the power of these model-based tools. So we have a number of ways to use models in bioequivalence. We can have a model integrated approaches where we can adjust bioequivalence limits, for example, in a switch study. We can use, sorry, that was a model informed approach. We can also use model integrated approaches where we actually use a model to inform us whether there's a difference through simulation. This allows us to reduce sample size or reduce study duration, create new innovative study designs that should make bioequivalence studies more feasible. And this may be especially the case in currently challenging situations like long-acting injectables. So we have two papers coming out that will be talking about a specific situation, paliperidone with schizophrenia, and how these two methods can be improved with a switch study in those situations. They'll be coming out in the next few weeks or so. We also have a software package that will be released on CRAN that will enable you to do this model-based bioequivalence using R and some additional tools. So stay tuned. I'd like to just acknowledge that the research that we've been doing here has been funded by 2 FDA contracts. It's been very rewarding. And so I'd like to thank my colleagues at the FDA, as well as colleagues at the University, Uppsala University. Thanks very much.
Hello, everyone. It is a pleasure for me to entertain you today about model-integrated bioequivalence approaches for long-acting injectables. My name is Murray Ducharme. I'm President and CEO of Learn and Confirm and a Professor Associate at the University of Montreal. The plan of the presentation is the following. We will first define what model-based BE approaches are, what long-acting injectables are, when it is beneficial to use a model-based approach, the principles of them, so the types of the model-based BE, the population PK algorithm, whether the clinical study design can be parallel or crossover, whether you have a complete or incomplete sample size. Then we will also discuss model-based BE examples. We will see how it's important to characterize the long-acting injectable with the population PK, how it is important to plan, differentiate, and validate the clinical study design approach that one wants to use in terms of alpha, error, and power assessment, the importance of meeting the FDA through the product development meeting, and finally, conducting the pivotal clinical study followed by the proposed. A model-based BE approach is basically any approach where one uses a model for the pivotal assessment. The US FDA was really innovative in that regard when they published their first guidance using a model, and that was the 1995 skin blanching guidance, in which a model is used to fit the pilot data. But that was also followed by many other guidances using models such as the IVIVCs, the US Office of Generic Drugs, individual product guidances that uses dose scale analyses. A few years ago, we published a paper on model-based BE approaches. In that paper, there's a table, table 2, which basically highlights different situations in which model-based approaches can be very useful compared to standard ones. So I really welcome you to have a look at that paper and at that table, because it's much more actually than just for long. The FDA has proposed the term model integrated BE approach, and there's a paper published in that regard by Dr. Zhao and its colleague also from a few years ago. And a model integrated BE submission is actually any submission where the pivotal information uses a model-based BE. So it's important to use model-based approaches only when it's beneficial. So if you have a product for which you can do a standard approach, and the standard approach is easy and is robust, reliable, etc., then there's no need to do a model approach. But sometimes, and this is the case of certain long-acting injectables, they liberate their active ingredient over such a long time period that it becomes unfeasible to do a bioequivalence using a standard clinical approach. Also, model-based approaches are theoretically useful when, from a technical point of view, the standard approach would not be robust enough, or also when it would not be feasible from a monetary standpoint. Long-acting injectables are injectable products that are modified release. So they're injected in the systemic circulation, but within the systemic circulation, they will liberate the active ingredient over a very long time period. So it means that you can have differences between the test and the reference product in terms of relative bioavailability, even though it's administered IV, and obviously differences in that liberation of the product. On this table is presented different drug examples. So on the left, you have the active ingredient. Going to the right, there are normal elimination half-life, normal dosing interval, which is usually given once a day or twice a day. And then you can see that there's long-acting injectables that are available for these products. And instead of administering them once a day with those long-acting injectables, you can administer them, for example, every month or even every 3 months. On this table now is presented the examples of products that we just showed, what would be a standard approach in terms of parallel or crossover, whether it would be feasible, then it's in black, or not feasible, then it would appear in red, and what would be an example of a model-based BE approach that you could use for these products. So if we look at Depo-Provera, for example, the Provera is a long-acting injectable of medroxyprogesterone. What is nice with this product is that you can administer it in postmenopausal women. So you can do a single dose parallel study design in postmenopausal women and follow concentrations for 4 months, having for example, 145 people finishing per group to have 90% power. So that study is actually feasible. And so you would not need a model-based approach for this product because it's feasible. But if you would want to do a crossover design in patients, then actually that study would not be feasible. Abilify Maintena is a long-acting injectable of aripiprazole. And this is a once-a-month product. So you can do a steady state parallel design study in patients. That would be the standard approach. It is feasible, although very difficult to do, if you do this parallel design, as you would need to dose the 2 products for 7 months in each group, have groups of at least 180 to have 90% power. So again, feasible but difficult. But if you want to do a crossover design, then really that study would not be feasible because it would take at least 21 months. In contrast, you can do a model-based analysis for which you can characterize the test and the reference product over 2, 4, 6, or 8 doses. You can compare this different clinical study design in terms of alpha, error, and power and propose the one that you would think is the most robust, discriminative, and the most appropriate to use. And you would only need to finish with n equal 24 or n equal 28 if, for example, you have at least a 4-way fully replicate design, because then theoretically you could use the scaled benefit of the model-based approach in this regard. On this table here is presented the examples for the paliperidone long-acting injectables, Invega Sustenna or Invega Trinza. Invega Sustenna is a once-a-month product, so it is similar to Abilify Maintena in that a steady-state parallel design is feasible, although very difficult. 8 months study duration in 2 different groups of at least 180 patients per group, so it's still very, very difficult to do. But a crossover design is really not feasible because it would last 24 months. Invega Trinza is a 3 months dosing interval product, so because of that dosing interval, even a parallel design is not feasible because it would take at least 18 months to conduct. A crossover design would take about 5 years to conduct. But if you do a model-based analysis, you can propose study design of 2, 4, 6, or 8 doses. You can compare them convince the FDA, which is the one that is the most discriminative and the most appropriate to use. And again, if you have at least a 4-way fully replicate design, then you would only need to finish with N equal 24 or N equal 28 patients to have your 80 or 90%. There are two main types of model-based BE. The first one is what we call virtual bioequivalence. So this is where the pivotal assessment is conducted in virtual patients, not real patients. So in order to do that, you need to have a population PK model that has been validated for this purpose, validated to be able to simulate new patients. And in practice, it's very difficult to do, very difficult to validate model and be completely 100% satisfied that that model will be completely accurate in simulating new patients. And but on the positive side, what is nice is that you don't need a clinical study design with the perfect number of subjects to have 80 to 90% power. So let me give an example. Let's say worst case scenario, you would need a study with 200 patients. Then if you would use a virtual BE model-based approach, then maybe you could do a study in, let's say, 24 patients and validate the model that you're going to be able to use, and then just simulate, let's say, 1,000 bioequivalent studies of 200 patients each. The other approach is where you do not simulate new patients. So actually, the clinical study design that you will conduct has to have the complete sample size that will result in the 80 or 90% power that you want. And all you need to do is characterize the PK of the test and the reference product in that study design. And after that, you can continuate in silico the dosing to these exact same patients in a clinical study design that you think is the most robust and discriminative. So for example, if you're talking about paliperidone trenza, then you would dose in silico those patients in a study that would last 5 years. So you would have, let's say, 20 months of dosing of the test product, followed by a washout, then a 20 months dosing of the reference product. There are two main types of population PK analyses that one can use. There's the one that we call the first order conditional estimation with or without interaction as implemented in Non-MEM. This is the most experienced tool that we have for population PK. On the positive side, there's many useful add-on tools that exist to simplify, automate analyses. There's Expose that comes from Professor Carlson and Professor Hooker from Uppsala University. There's Wings that comes from Professor Halford of New Zealand. On the negative side, there's some limitations on the complexity of the model that can actually be coded within Non-MEM. And this is a problem because long-acting injectable are actually very complex products. And so the model that you need to code is actually very complex sometimes. And with this tool, you also have convergence and stability issues. You may also have some translation issues between what you code and what actually Non-MEM does behind the scenes. The other approach is what is called an expectation maximization method. The one that we prefer and that we judge to be gold standard is the MLEM as implemented in the ADAPT5 tool. In that one, there's no limitations regarding the complexity of the model. The results are very robust. We've done internal research studies ourselves and have shown that the results using this method are actually better than the ones that we obtain with Non-MEM or with Non-MEM using an EM approach. But on the negative side, it has a slow runtime. The convergence criteria can be misunderstood by people. There's few add-ons available. But similar, but not identical, algorithms can be found in Certara, NLME, Monolix, and non-mem. So we've discussed a little bit about this, but a model-based clinical design can be parallel or crossover. Here we will make a big difference between the two. We argue that a model-based analysis should always use a crossover design, because that's the power of the model-based analysis, is that if you fit data of the test and the reference product within the same patients, then the only parameters that can be different between the test and the reference are the ones that are associated with the liberation of the active ingredient and the relative bioavailability. But all of the systemic and non-formulation related parameters will be the same. While if you use a parallel design, then you read on all of that. And all of the PK parameters theoretically need to be different between the test and the reference. And so because of that, you're really missing on the power of the model-based analysis. It also can have either a limited sample size or a complete sample size. If it's a limited sample size, you're going to do a virtual BE study, as we mentioned. If it's a complete sample size, you can just continuate dosing of the patients that you've already included in your study. And again, how are you going to propose this clinical study design that will have a model-based analysis in it? First of all, you need a population PK model, needs to be validated. You need to compare the different study design to a standard one and show that the design that you're proposing is adequate in terms of power and alpha error. And once you have that, you're going to propose that design to the FDA. You're going to submit it as part of the product development meeting. The FDA will have very useful comments for you in that regard. And once you agree with the agency on what the next steps are to be, then you just conduct them. And so right now, what I would like to do is just summarize what we've seen and what we've discussed with two different slides of flowcharts. So first of all, how do we find that alternative clinical study design that we're going to conduct and that we're going to propose to the... First of all, we need a published population PK model describing the reference product. If we have that, then we need to look at it. Is it missing something? If it's not missing anything, then you can just test all of the different clinical study design that you can think of, and you can test them in terms of power and alpha error so that you can propose the clinical study design to the US FDA that you think is going to be the most appropriate, most discriminative to assess equivalence using your model-based analysis. Often, there are no population PK models that are available in the literature or in the NCAPPC, or there is something missing in the population PK model that is published. So, for example, very often, inter-occasion variability may be missing. So if inter-occasion variability is missing, then you really have something missing in the model, because you cannot really predict what would happen if you would do a fully replicate clinical study design. So if you're in this situation, then it's better to do a small pilot study in which you could replicate only the reference, for example, then you create or you improve the population PK model that is available, and finally you do the rest. Once you have proposed that clinical study design to the US FDA, when you're going to This flowchart summarizes what you're going to do during the model-based analysis. So first of all, if you have a crossover design, if the sample size is complete, then you do the clinical study, you fit the individual study data with a population PK approach of the test and the reference product, you validate the model for the individual fitted results that you obtain, and once you have validated the model, then you can just continue in silico the dosing of those exact same patients and determine the bioequivalence in the optimal dosing conditions that you would want. And so, for example, if it's in Vega Trinza, that in silico study could be a study of 5 or 6 years in duration. If the sample size is not complete, however, then that's going to be a virtual BE model-based analysis. So the model has to be pre-specified, pre-validated for that purpose. It would be best to do a small clinical study where you would internally, again, or externally validate that model, and then you could conduct the virtual BE study, let's say a minimum of 1,000 studies. If you want to use a parallel design, which we would not recommend, but if you would want to use that, then at least if the model that you have has covariance on the systemic PK parameters, then that is something feasible. But the model has to be pre-specified, pre-validated for that purpose, and then you can do your virtual BE analysis. If there's no covariance in that model, then it's really not worth it to do a model-based analysis. So in conclusion, we would argue that model-based BE analysis, which are proposed by the US FDA, are a major advance in establishing equivalence of complicated products, such as long-acting injectables. We've seen that different types are available, but we would argue that the most robust and reliable one to use is one where you use a crossover design, complete sample size, and where you continue the dosing of patients in silico to whichever study design you prefer to establish bioequivalence. Thank you for your attention.
Thank you for the speakers from the session 2, as well as thank you everybody for your attention. So we have 3 minutes before the 11 a.m., but I think we can have a 5-minute break, 5-minute more break, and come back by 11:05. Thank you.